Patient's arterial blood gases are as follows. Her pH is 7.39, which is in normal ranges. Carbon dioxide is 6.5 kilopascals. This is elevated. Normal range is between 4.7 and 6.0 kilopascals. Her oxygen is 7.5 kilopascals, which is decreased from normal values. Normal values range between 10 and 13.3 kilopascals. Bicarbonate is 30, which is elevated. Normal range is between 22 and 26, as well as the base excess is also elevated at +4. Normative values are between -2 and +2. CRP value is 10. This indicates some sort of viral load or infection. After looking at her blood gases, it appears that the patient could be in fully compensated respiratory acidosis with type 2 respiratory failure. Moving on to the chest x-ray, seems to be a slight right deviation of the trachea. This may indicate volume loss or increased fluid. This coincides with the heart failure that is in her past medical history. There's no obvious fractures. However, there's potential osteoporosis present in the right lateral lateral ribs, specifically around ribs 4, 5, and 6. They just appear brighter white on the x-ray. There's a decreased size of the heart. It does not occupy 1/3 of the chest cavity. Also, the cardiophrenic angles appear blunted, indicating volume loss as well. The costophrenic angles also appear blunted, indicating some sort of fluid buildup or volume loss. The chest cavity appears underexpanded because less than 10 posterior ribs are visible. The fields are evident, however, there's some consolidation in the right middle lobe of the lung. There appears to be no shifting of structures. There was no gastric bubble present, however, the hilia appears enlarged and flattened. This could indicate some sort of chronic infection, and this coincides with the elevated CRP. There was no pacemaker, however, electrodes are visible. The patient is a 78-year-old female coming into the hospital on recommendation from her GP. This is her second admission in the last 2 months. She presents with shortness of breath at rest, started 3 days ago. She also is fatigued with bilateral ankle swelling. She took prednisolone 2 days ago. There's no improvement since taking that. She has difficulty mobilizing, completing her activities of daily living, and which ties into her physiotherapy problems that will be later discussed. The patient's physiotherapy problems are as follows. First off, her increased work of breathing. The patient uses her accessory muscles, and also her expiration is active when it should be passive. Patient presents as fatigued with difficulty mobilizing, completing activities of daily living, which coincides with her excess use of accessory muscles for inspiration and expiration. The use of those muscles will lead to using up energy stores, ATP, and feeling fatigued. The second problem is reduced lung volume. So in observation, the patient has decreased air entry bibasally, also has quiet breath sounds and decreased thoracic expansion, indicating a lack of ability to fill her lungs with air. Third problem is exercise intolerance. The patient baseline used to be shortness of breath on minimal exertion, which was 10 meters walking. But as of 3 days ago, the patient is now short of breath at rest. Also, she's finding it increasingly more difficult to go outside and mobilize using her 4-wheel walker. Patient also reports difficulty mobilizing around the house, which she used to do independently, as well as completing all of her activities of daily living, which she can now no longer do. Sputum retention, although on observation there was no mention of sputum retention, in the chest x-ray there appeared to be some sputum or consolidation in the middle lobe of the right lung. Also, when looking at her drug history, she does take a medley of prescribed drugs for COPD that she's been diagnosed with. So assuming that she is using those to combat sputum retention. Besides that, she does have a cough, which is strong and dry. the cough indicates that she's trying to mobilize some sort of secretions, even though she may not be able to get them up. As far as pain, there was no pain mentioned. For the most likely pathological process leading to this presentation, the patient has been already diagnosed with COPD. However, I understand that could be one of 3 different pathologies. In this case, the most likely one, I believe, is chronic bronchitis. As the patient has a long-standing history of smoking with 40-pack years, they've subjected themselves to long-term progressive damage to the bronchi and bronchioles. COPD and chronic bronchitis is common in those with long-standing history of noxious agents, such as smoke inhalation. Despite there being a non-productive dry cough, the patient presents with airflow obstructions, as air entry was diminished basally on auscultation. Persistent cough also indicates damage to the mucociliary escalator, as a cough is now required to remove sputum when originally that would have been done by the mucociliary escalator. Furthermore, the patient has elevated carbon dioxide, which is also common in those with COPD. As mucus increases, the thickness around the alveoli and capillaries makes gas exchange more difficult. Similarly, they present with low levels of oxygen in the blood, demonstrating difficulty with gas exchange at the blood-gas barrier. Continuing with hypoxia, it causes vasoconstriction in the lungs, and as the blood travels to oxygen-rich areas to maintain status quo for VQ matching, this could potentially result in pulmonary hypertension. Increased pressure at the lungs then puts pressure on the right side of the heart, resulting in hypertrophy. Therefore, the right side of the heart loses its ability to hold on to blood. This causes a buildup of blood, which the heart doesn't really like, and therefore water seeps out of the blood and into the capillaries, and that causes peripheral edema, which the patient presents with, and bilateral ankle swelling. I want to note that in her past medical history, she does have a history of heart failure, which peripheral edema is also common in those with heart failure. When looking at the psychosocial issues that could be contributing to the patient's current presentation, I broke it down into modifiable and non-modifiable and modifiable risk factors. So speaking on the modifiable risk factors first, smoking is the first one. So the patient is an ex-smoker, however there's no mention of how long ago they quit smoking. All we know is they had a 40-pack year history. She also currently lives with her husband, who is a current smoker. So being in an environment where there's noxious smoke that's still present may contribute to her symptoms. As COPD is progressive and irreversible, damage to the mucociliary escalator due to damage to the cilia is possible, thus resulting in her cough. Furthermore, her inability to clear these secretions, coupled with the potential fluid buildup around the heart, increases pressure on the alveoli, as well as thickness for limiting gas exchange at the blood-gas membrane, especially basally because it's mentioned in both lungs. This increase in pressure and thickness in and around the alveoli makes it difficult for gas exchange to occur. This diminished gas exchange leads to the hypercapnia and hypoxia that we see in her ABGs. The second modifiable risk factor is physical inactivity. Patient has recently, 3 days ago, went from just short of breath on minimal exertion, which was 10-meter mobilizing, to shortness of breath at rest. Her recent decline in physical activity could be contributing to the symptoms of fatigue that she also has, and also not being able to complete her ADLs or mobilizing independently like she used to. However, she has also been refusing carers who would be able to help her complete her ADLs as well as mobilize, and inherently doing those things could help reduce symptoms of fatigue and shortness of breath if she were to do it often and build up some sort of endurance. A potential decrease in fatigue could occur with the aid of carers, as the patient would be more active daily, as I mentioned. Furthermore, it is noted that the patient has found it increasingly difficult to go outside. There is a lack of railing outside, and this could cause apprehension for the patient, making them more reluctant to mobilize independently. For the previous 10 meters, that was considered their baseline, thus resulting in fatigue, atrophy of muscles, and therefore inability to mobilize, and do her activities of daily living. Moving on to the non-modifiable risk factors, I only have two of them. The first one being age. As previously stated, the patient is 78 years of age. COPD is much more common in an older population as their lungs have been subject to more damage throughout the years, where they come from air pollutants, dust, smoke inhalation, which she has definitely been exposed to, and still is experiencing living with her husband, and also chemical inhalation. The other non-modifiable risk factor is her ethnicity. Although I don't know what her ethnicity is because it's not mentioned, it's not possible to say if there's any predisposition to the pathology, as COPD is present across all ethnicities.